Hello everyone, welcome back to the channel. We are here with adjunct professor at the University of Pennsylvania, Mwaya. Today we're diving into a case that highlights some of the most pressing challenges in healthcare homelessness, chronic illness, and systemic inequality. Meet Mr. Johnson, whose name has been changed for privacy, who is a 65-year-old African-American man with heart failure, a history of substance abuse, and over 20 ER visits in the last year. His story isn't just about medical care, it's about the gaps in our system. Let's unpack this together.
Yes, hi. Thank you for having me again. I'm glad that we're talking about specific issues, especially with social determinants of health, right? Because that is also part of the population we are serving in value-based care. And from what you've introduced about this gentleman, it already sounds like he already has one thing that is part of social determinants of health, and that is housing. You mentioned that the case study, the gentleman is unhoused. Did I hear you right? Okay, so go ahead.
Correct. That is correct. And so this case study, we're going to be titling Breaking the Cycle, a Homeless Patient's Struggle with Heart Failure and Addiction. Anyone in the medical field who's ever dealt with anyone with heart failure knows that there's a lot of issues such as the upper and lower extremity swellings, particularly the lower extremity swelling, fluid retention. Oftentimes, if the heart failure is not properly treated, and you also have issues with a lot of like congestion. So you may have someone complaining of trouble breathing, a lot of issues around physical activity. And the crazy thing is, once you start looking at a lot of those situations, for example, someone who has heart failure that is not being properly treated and all of the different conditions that can come from that, you start thinking about some of the interventions that you would use, let's say for someone who recently had a fracture, right? So you know that person needs a lot of physical therapy. They need assistance with mobility. So oftentimes individuals with heart failure that is not properly treated, they usually need walkers and canes and things like this. So you start finding out that this person is really having a hard time getting around. So you can just imagine what it's like if a person's homeless and they need this kind of equipment. They need durable medical equipment, DME. And
Right.
so what happens when that person is transient, they're moving from place to place, and you kind of try to find where they left their cane, where they left their walker. And if they're frequently going to the ER, oftentimes this equipment is left all over the ER. And if those individuals choose to stay, because oftentimes frequent flyers at ER, they will just go into the ER for just a warm night, something to eat, try to see if they can get some meds, and they'll say, no, I don't want to stay. They don't want to be tied down by the bureaucracies of the hospital stay. So they'll leave. And with that, oftentimes they'll leave their walker cane in the ER. They never move into a real bed. If they go to a real bed, then the walker and cane is left in the ER. I mean, I've seen this play out in so many different ways. And unfortunately, because they're transient, it's very hard to come up with interventions to replace DME if it's ever missing or out of place. And so Mr. Johnson is homeless. He's living in a shelter when possible, but often sleeping on the streets. He was diagnosed with heart failure 3 years ago, but struggles to manage it. His legs are swollen. He's constantly short of breath. He is in and out of the ER. He also battles alcohol and opioid use, which he admits help him cope with trauma and the stress of homelessness. Now, I'm just going to let this stay here. Linda, can you tell me what your experience has been with working with individuals with a similar background, a similar history?
Yeah, so I have had patients like Mr. Johnson, a lot of them actually, and coming from my insurance background, I once encountered such an individual because he was costing the insurance company $100,000 a month. And you did not mishear me. Yes, that's a figure. Not 10,000, not 5,000. He was costing that particular insurance company $100,000 a month. So your question would be, why was he costing them so much? Because every time he went to the ER, it's hundreds and thousands of dollars, right? And what happens is hospitals love people like Mr. Johnson, okay? Because they are basically a money maker for them, especially if they are on Medicaid. Not to be judgmental, but that's the truth, because they know that Medicaid will pay for the bill no matter what, right? So the ER, as you mentioned, is not a place where people go to get well, right? It's crowded. They are not dealing with the real issues an individual like Mr. Johnson has, because you mentioned that he is unhoused, he has heart failure, he needs DME to get around, right, because of his edema, and he's also battling alcohol and opioid use, which he says he uses to cope with his trauma. But what you have to understand is that an individual like Mr. Johnson, from my perspective, and I'm not a doctor, I'm not a specialist, but I would say that from what I've had on hands-on field experience, is that the best thing for him would be first to get him into a treatment center to treat his alcohol dependency, right? Because you can admit him in the ER 3 or 4 days, okay, he would temporarily be without those substances, the opioids, the alcohol. Does that make him well? Does that make him cured? No, you're putting a Band-Aid, right? Because as soon as he gets discharged, he will most likely go to the corner store and get his alcohol again, regardless of what the doctor's instructions were. And this is actually factual. When I had an individual like Mr. Johnson, I couldn't find him. He was hard to find. But after reading his chart and finding out all these issues he had, sure enough, I was able to locate him. I want you to take a lucky guess. Where do you think I found him when he got discharged and we couldn't find him?
I'm thinking either in front of a bar or in front of a beer distributor.
It was actually in front of a corner store beer distributor. And
wow.
Yeah, good guess. Very good guess. And that's how I was able to engage with him and try to get him housed and all those other things, But what I'm saying and why I know that our conversation is leading up to something else. What I'm trying to make a point in this is that these people do not belong in the ER, They belong with a primary care physician who really cares about the outcome and less hospitalizations. Because if you had a good primary care in plan who was looking after an individual like Mr. Johnson, he would make sure that he gets him into treatment. He would make sure that he should have someone like my line of work, community healthcare worker, social determinants of health people, to find him to have housing. Because you also have to remember that Medicare doesn't buy these walkers or whatever DMEs. There's a 5-year limit. I don't know if you know that.
Yes.
So every time he loses one, basically, unless the hospital are going out of their way to get him a replacement, that's not going to get replaced by his insurance because he needs to wait 5 years, right?
And this speaks to something else too. Oftentimes when they do have DME replaced, if they're not connected with the right type of resources, oftentimes that DME is DME that they found, which means that it could be broken or not really properly fitted. And I mean, I'm no OT, PT specialist, but from my understanding, a lot of this equipment has to be kind of modified in a way to help that individual, obtain optimal ambulation and safe ambulation. So therefore, if they just pick up a walker or cane just because it's available, it could actually be for someone who's much smaller than they are, shorter than they are, taller than they are. So
sometimes heavier.
Exactly. And it can cause more harm actually to that person in long term because that equipment is not actually fitted for them. specifically. So as you were saying.
Yeah, so for a person like Mr. Johnson, like, I think that the medical system needs to come up with a better form of care for them, you know, to really take care of them, and rather than see them as, oh, let's make as much money as we can off their Medicare insurance and keep admitting them, you know, because of course they're not going to deny them admission, you know. So, and what in most cases, and you can correct me if I'm wrong, most of the time the hospital will keep them for 2 or 3 days, you know, and then they discharge them, you know. And
Right, because hospitals have their time frames for how long they can keep someone before they either make a decision. I think it's a midnight rule where you have to kind of make a decision: is the person going to be admitted or not?
okay. I
Right.
didn't understand. Okay, yeah. So, and then you guess what? Next week, Monday, guess where is Mr. Johnson again? He's back.
Wow.
Yeah, he's back in the ER. So, what I'm finding, you know, and I didn't get into healthcare because I wanted to make money. You know, I come from a third world country, you know, and I know that lives can be saved if we have the right prevention processes in place. But what I'm seeing with the healthcare system in our Western world, in our developed world, I should use those words, is that I don't think they really care about individuals, especially people like Mr. Johnson. I think to them is, okay, they have Medicaid, let's see how much money we can use them to manage our overhead. I'm sorry, but this is my opinion, because I keep seeing this over and over again, and it's not getting better. You know, it's just wastage. It's spending money over and over again and not solution focused. Because what solutions would they have in place that would be helpful? First of all, how about helping him really get into long-term treatment, you know, and managing his heart disease, managing his substance use disorder, managing his homelessness, so that he has a stable home, a place where he can actually go, and you can have like a home visiting nurse, which is much cheaper than him going into the ER, right? And can actually keep up with him and see how he's doing, because this is costing. And yeah, these are my tax dollars. I'm sorry, they are. And I feel some type of way, because I'm like, what am I paying for? You know, I'm paying to help Mr. Johnson, or I'm helping University of Penn Hospital System. I'm just using an excuse, or Jefferson or Temple just get more money from this individual, you know?
I think,
Mhm.
well, so what I think I hear you saying is, how can we help these individuals? Can they be helped, right?
Yes.
So you realize that, okay, we have healthcare professionals, we have social determinants of health specialists and, experts in that area. We have resource specialists. There's so many different individuals. We have people who do program management. There's so many different
transitional care
professionals.
nursing. Yeah, transitional
care,
nurses.
Right.
Yeah.
There's so many different players, social workers, case managers. There's so many different players. But I think oftentimes what happens is, in systems where they are trying to reduce their overhead and their spend, and they decide they're going to work the like skeleton staff, the reality is that many of these patients kind of burn out the staff, and the staff become jaded. And once they become jaded, even simple interventions cannot be executed because you don't have the right amount of people to actually make it go. So
I'm sorry to interrupt you,
sure.
Raquel. I have a question though. What happened to the first law in medicine, which is thou shalt do no harm? What about?
Here's the thing. The thing is, in situations where, and this is just my personal opinion, you shared yours, and this is my personal take. If you have finance folks, and you have IT people and people with background in engineering, and you have them in your, doing your leadership. Or maybe you even have a medical doctor. So that medical doctor is probably very much committed to that Hippocratic oath that, that they, want to do the very best for the patient. They don't want to cause any harm and everything that they're committed to. But the truth about the matter is, even they can be very idealistic in the way they're thinking about things, because of the fact that, again, you have this idea around how you think people should function on the front line, but you're not really giving them enough support. So therefore, if you have engineer and finance folks at the top, they're going to deal with it like well, look, the legal folks are going to do everything they possibly can to keep you out of trouble. The finance folks are going to do whatever they can to make you to help you make profit, right? And then or to at least keep you out of keep you out of any of the out of prison, right? So you're not spending money because of fines and things. And then you have your engineer folks that could be treating the whole operation as if it's like, building a car. And so everything comes down to who's at the top making the decision, and what is their vision, and also what is their understanding about processes and workflows. And oftentimes you should be surprised by this, but you'll have medical doctors who probably mean well, but they're not on the front lines. And for many of them, they don't have the business acumen. So therefore, if they don't have that, I'll put it simply like this. If a medical doctor has either business and or engineering or project management somewhere in their background, I find that those providers are better suited for leadership. Oftentimes that is not the requirement. So if your background is in medicine and the opportunity presents itself and they want a doctor go in that position, and you're MD, you got a DO, whatever, and the opportunity presents itself, you go ahead and take the position. You take the position not understanding business. You're just thinking about things from a provider perspective. So maybe from a quality perspective, or what should be the best next action for us to take with a patient like Mr. Johnson, you probably have it outlined. But if you don't know how to take care of staffing, if you don't understand, how to properly, factor out salaries and budgets, then your idea about things being how things can be accomplished could be just very idealistic. It's not based on the population you're actually serving. So this also requires leadership listening to information from the front line to understand the perspectives of those individuals who have to directly take care of Mr. Johnson, not just take care of Mr. Johnson because he's just a number of, just a medical record number, or he's just another number of the head count of patients for that day or that month or that year or that quarter.
Yeah, well, in a case, if I was in leadership, let's just say at any place that we had a client like Mr. Johnson, he has medical heart failure, no stable housing, substance use, right? There are 3 types of people I would make sure that I connect Mr. Johnson with. Okay, first and foremost, I need to make sure that he connects with someone who is a community health worker, right? Somebody he's familiar with, someone from his own background who speaks his language, and that can build a relationship. So you're going to ask me, how long should the community health worker work with him? When does she terminate? When does she say, Mr. Johnson is at a good place, I don't have to work with him anymore? First and foremost, stable housing. Am I going to find him stable housing? We can't think of job opportunities because the man, from the way he sounds, he has edema, his medicines can't work because he doesn't have refrigeration, right? And those are all part of treating the whole person, Raquel, in how to make him better. But they're all failing because of systems are not in place. If he had stable housing, then he would also have a refrigerator. Most apartments, rooms, or whatever, we all have fridges, right? Then we know his medication will be good. Then we know that he will have food security. Then put him in a neighborhood where maybe they have alcohol or outpatient treatment services, with people in his own neighborhood who are struggling with the same issues, because people tend to think collectively, especially people who are in addiction, they work better if they are put together with people who they are familiar with. I bet you if you gave me a client like this, if you gave me a year and say, let's see what you can do, and then I will assign a transitional nurse, okay? Transitional care nurse to make sure that, okay, Mr. Johnson, did you make your appointment? Are you following up with care? Did you do what the doctor asked you to do? Then I think that Mr. Johnson might be able to break out of the circle, then he might not go back to the ER, then he might not go back to his addictions because he has some sort of security and stability. But what I'm finding and what I'm seeing in a lot of places is that I don't think they really care about Mr. Johnson as an individual. I'm telling you, they see him as a medical record number, and let's get as much money as we can from this man. And when they are tired, these kind of places, they're like, oh no, discharge him or make sure that he changes his insurance so that we don't take it anymore. You know what it is? That's using someone like toilet paper. I'm sorry to use that analogy, but it is true. You take your toilet paper when you're in the bathroom, you use it and you flush it, and that's what's actually happening in healthcare with people who are on Medicaid.
Funny.
That is my opinion.
Mm-hmm.
You can also you can deny it and say, oh no, I haven't experienced that, or Monda, I tend to be an exaggerator. You would say that, but I don't think I'm exaggerating because I have seen cases like this over and over again, and I'm like, how are you getting away with it?
I agree with you. I honestly agree with you, especially around the point of Medicaid, because oftentimes your insurer says a lot about how healthcare systems will treat you, oftentimes because the stigma. It's no different than the stigma of if I've seen it before where maybe someone of color, particularly a Black individual, Black patient, will have something in their record that they're a retired physician or they're a retired engineer, or maybe, their children are somebody like really notable, maybe even somebody like a celebrity. And all of a sudden that now becomes the indicator for how the quality of care is going to go. And I'll even make my point further. In two situations, my mother and my aunt were both recently hospitalized. And in both situations, myself and my sisters had to actually go to the hospital and kind of more so advocate for them to kind of say, hey, how are you doing? Just want to let you know, we're medical professionals. So,
right. So we know what's up. The jig is up. That's what you were trying to tell them.
Exactly.
In a polite manner, though.
And even more recently, because the situations that's going on in the hospital where the staff members, the numbers are low to ratio, the patient staff ratio is where it's at. As far as the staff, I should say the staff low and the patient staff ratio is in balance. It's not in balance, right? So therefore you have, let's say in some cases on a med-surg floor, you can have as much as 7 to 8 patients assigned to a nurse. And everybody knows that those kind of numbers, like I think in California, they had capped it to 4 or 5 for med-surg. And those kind of issues, they become compounding problems, because one of the issues that I think tends to get overlooked is the fact that the acuity of the patients is something that the hospital system actually has control over. So they can take a patient that maybe should be spending some more time in the ICU and put them, drop them down into or transfer them down into med-surg. And this person requires just as much attention and the intervention that you would see in ICU, because in ICU it's usually like a 1 to 2, 1 nurse to 2 patients tops. And so what happens if you are taking care of a patient in med-surg who probably still needs that level of care and attention, then you're probably really putting your license at jeopardy to some degree. And my numbers could totally be off. Someone could hear this and say, well, my ICU, we can go up to 3 or 4. That's typically not the case. But I know in med-surg floors, because there's an assumption that patient has met the criteria to be on a med surg floor, that the nurse now needs to step his or her game up. And that's where a lot of this problem comes in at, where people start finding little indicators for them to cut corners. And so going back to what I was saying about my aunt, she's older adult. She
When you mean older, is she like in her 70s, 80s?
She actually 90. Okay. 90 years old. She had wrist restraints on because she was displaying some confusion. Understandably, she's having a significant trouble breathing. She had onset of some confusion when she was home.
Can you just hold on? Why did she have wrist restraints?
She had the wrist restraints because she was starting to, before admission, she was showing some signs of confusion, just some. But when she was admitted, I think when they noticed that she had this confusion, they were concerned about her ripping out any kind of IV lines that they had established. Her admitting diagnosis was related to a respiratory issue. So therefore she was having trouble breathing. But when I had visited her just in the time she was in the ER, they had discontinued the breathing treatment. So therefore the breathing was no longer an issue. And there was another issue where they were thinking about having some type of cardiac related surgery. Now they were unclear if they were going to move forward with the surgery or not, because she was pretty stable, as they were monitoring her levels. She was pretty stable. But the issue was that every single day that they were trying to figure out if they were going to move forward with surgery, they kept putting her NPO. Now, the thing about it is we're talking about someone who's probably a little over 100 pounds. She's really tiny. She's like just at 5 feet, really tiny. She is showing you some signs of confusion. You put the wrist restraints on her. She has a respiratory condition that due to a virus. So therefore she needs to be on some kind of isolation, some kind of contact isolation. So therefore some precautions around, contact with her. So, you have to kind of gown up, put a face mask on if you really want to be safe when you're interacting with her. And so all of these things really can create real social isolation. The worst thing about it is because of this issue, this NPO issue, every single day, she might have been in the hospital for like 5 or 6 days, every single day until, let's say, midway. They really initiated this NPO from midnight, not knowing if they were going to do the surgery in the morning. So every morning I had to present to the hospital to find out, are you guys doing the surgery? Because if you're not, she needs to eat. And I started doing that. Just let me finish. I'll just add this piece here. The reason why I had to do it that way was because the first day when she was she was told that I was told that she was not going to be eating anything for that day. It was unclear if it was because of NPO or her refusing a meal. And then I had the nurse call me back the nurse in the ER called me back, and she did call me and she explained to me, the doctor is not having her on NPO, so she can move forward with a meal. But she did refuse the meal when it was offered to her. And so at that point I said, well, she's confused, right? So my thing is, if she's confused and you haven't seen her eat anything and she's not NPO, then what would be the other intervention that you would put in place? And the thing that is unfortunate about this is many nurses will say, hey, don't beat a nurse while she's down. You don't know how stressed out she is and everything. But from another standpoint, I would have to say, as a nurse, this is my aunt. And if I walk away and no one's here to feed her, and I could clearly see that no one was there to feed her, that means that we would have to, as a family, every single visit, be either prepared to stay throughout mealtime or come there with a meal with intentions of feeding her as long as she's not on NPO. Long story short, halfway through her hospital stay, which was about maybe 5 or 6 days or so, halfway through the hospital stay, they decided not to move forward with the surgery, but every single day she was still kind of being treated with the wrist restraints as a confused fall risk patient, and all of the train of thoughts that goes along with those type of precautions were in place. Kind of, what is she going, if we don't have the wrist restraints on her, what's going to happen? If you take the wrist restraints off, is she going to try to harm herself. It's all of those consequences and all of those concerns were there. But I personally did not see any interventions in place that would
And that's
stop
what
those
bothers
things to
me.
happen.
This is
Mhm.
why I was interrupting you, because
No, that's okay.
it
Mhm.
sounds like they are not really worried about interventions, but they're worried about lawsuits and other things. Like,
Yeah.
they seem to be worried about other things outside treating your aunt. Okay. And
This is just like what you're saying about Mr. Johnson when you said he was just a number. Just
yeah, he's just a number. And what I'm wondering, if you're saying your aunt is in her 90s, what kind of surgery were they thinking at a person who is 90 years old? That
would
was
benefit
it
from.
something that was life-saving? That was a necessity that she had to, was it medically necessary? Or was it
Right.
cost-effective for them so that way they can charge her insurance?
And another question is this: whatever that benefit is that something that you can explain to us, her family members, who now would have to help her because obviously she's confused, so that we would have to help her with understanding, because once we make that decision, then we have to deal with everything that comes with a person having a surgery, because now we have surgery, post-surgical care that we have to now be
Right.
okay with the antibiotics. We have to be okay with, now that she's a risk for infection because she has a foreign device inside of her body. Now we have to be concerned about who is now going to oversee
Right,
her care moving
aftercare.
forward
Yeah, aftercare. Yeah, every
exactly.
day. Wow.
Exactly. And is again the risk benefit. Listen, if you could extend her life to 100 more years, that would make my heart overjoyed. But to consider that you would actually cause more suffering, similar to this NPO thing, and I hate to put those two in the same space, but it's almost like, if every day she's NPO and you don't know for certain if she's moving forward with the procedure, that means every day she's NPO, you're putting her at risk for all the risk factors that come with a person who has not been eating, right? So it's like you have that thing you have to think about. So for me, it's like, what is the benefits of us moving forward with this procedure? Is this something that, again, we would be able to even have her to somewhat understand that there could be some benefit, and to what end, if we got her to agree to the procedure, and if she could understand somewhat why it would be necessary, would she actually want to deal with the antibiotics and all the stuff that comes with antibiotics? Because after the antibiotics, you have to be concerned with the side effects of the antibiotics, side effects of the new medication. So all of this are things that I feel like, going back to what you're saying about, just being a number, the family actually needs to have that kind of sense of assurity that the hospital and the medical team really wants what's best for the patient. And so, going back to Mr. Johnson, as we can see, he has heart failure, hypertension, edema, and then there's also, he's being prescribed medication. Like I was mentioning about medication, when a patient is transient there, and they're without housing, you mentioned it also, where do you store the medication?
Right.
When you're thinking about issues like having a lack of housing and food insecurity, is the medication as important as the housing and the food insecurity? We know Maslow's hierarchy of need help us to understand that would not be a priority, medication over housing and the food issue. And we also have to think about systemic racism, because oftentimes patients who, like Mr. Johnson, they are on the street, and bouncing from shelter to shelter and ER to shelter because of the fact that they don't really trust the institutions. They don't believe that these institutions mean them well. Now, someone could ask, well, is being on the street any better? No, but at least being on the street means that you don't have to deal with someone telling you untruths, right? And you can kind of navigate life for yourself, and you feel that sense of autonomy and that, sense of integrity around how you want to live your life. But you mentioned earlier also the issue around housing first. And I think housing first also becomes an issue with this population because of the history of homelessness and the chronic homeless behaviors, oftentimes individuals like Mr. Johnson may feel very comfortable at their particular spots where they usually frequent, whether it's in front of the beer distributor or whether it's on the bench in front of the library or the bench at the bus stop. They often feel very comfortable at those spaces because that's where they're expected to run into their people that they see every day, and they've created that sense of normalcy for themselves. And I think without taking care of the underlying issues, housing also becomes an issue within this population too, when there's a substance abuse, which I'm going to go to next. Because as you can see here, in this case, Mr. Johnson started drinking young, opioids entered the picture after a work injury, and the cycle of substance to numb his pain, but worsen his health, right? His heart health. And so this is not uncommon. I've seen in this population, working with the homeless population, and not homeless population per se. These are individuals provide care through a primary practice, but they have issues with homelessness, right? And so working with individuals, especially who are not stably housed, the issue around taking care of the underlying mental health issues is so important, because I have seen this backfire so many ways where resources are, directed to stabilizing housing, and the person will take the very place that they were provided and they will sell it or sell everything that's in it so that they can have access to the substances that they are abusing. So what has been your experience with that dynamic? Because that's such a common dynamic.
Yeah, housing is a tricky thing because I always think that without a home, you cannot get a person to have well-being, right? Because you're saying you give them resources, and sometimes they're using the same resources to actually support their addiction, right? If it was me and if I was running a place, I would, even especially in a setting where these people, we know that they, I don't know, like, have a certain contract with a housing person who can house these people for us, that way where to find them if they need follow-up appointments. Because even with transitional care, if the person doesn't have a phone, and usually these people have those lifeline phones, which they tend to run out of minutes, or they misplace them because they didn't pay for them, right? So in this case, I would say, stable housing should be priority, because I don't think you can really treat this individual unless you have a place where you can have frequent contact, send someone to find him, send a home visiting nurse to go see him and keep him stable. A home visiting nurse can come and see in your fridge, oh, I see that your prescriptions are being kept at the right temperature. I see that you're following this. Hey, let me take your high blood pressure. It would actually cut costs for the medical insurance company, because then the home visiting nurse would be making sure that he's following through. And then you have the community health worker who is also making sure that he has other resources like the food insecurity, like, food banks. This gentleman is not ready to work, but they would be able to help him seek employment when he was ready for work ready force, or, like job readiness, but that can only happen if you give him a stable home. You can't utilize all those things, meeting him in a crowded ER and thinking that he's going to get any kind of help from this, and this unfortunately happens with a lot of our population, because they don't have an address, like I'm stressing, so how do you provide follow-up care without an address or communication of any type? Phone, nothing, right? And then you have the ER people who are also dismissive, and they're like, oh yeah, here comes Mr. Johnson again. Already he's not getting the right treatment because from the door he's been judged like, oh, it's him again with his problems. You understand?
You're making such a great point about that, because one of the things I think that we tend to take for granted is that in situations where you're targeting, because we have to remember, practices, programs, they target populations, right? So if you're targeting a population that could actually have homelessness as an issue, I have seen that it works out best when the housing is a part of the services provided.
Yeah, it should be
Because if
about
you
the
just,
services provided.
yeah, it's like you can't pretend that the housing is not an issue, because what I've seen work, I've seen this in two programs in Philadelphia, in the Philadelphia area. One is Pathways of Housing, PA. They have, I think they have multiple locations, but Pathways of Housing, and I've also seen it in a company called Innovage. Now New Cortland, they were formerly New Cortland, now Innovage, in the Philadelphia area. What I noticed in both models is that a part of that enrollment is to stably house the person. So therefore, while there were times where this person could be out in the street and it'd be hard to find them in their apartments, because they had the apartments, or because we were able to provide care and keep them stably housed in their own homes, by creating the right type of interventions, we never really had to run around looking for them, And so, and then you can create with that transportation, you then provide that resource for them to get back and forth to their appointments, and even some cases have activities where you actually help them with social supports too. So you have like events, maybe you take them out to like a day out in the park. You maybe can take a small group out for like a shopping trip. And so these type of interventions work when you take care of that big housing issue. But I think the problem that I have is if you're trying to work with a population, and your population that you're caring for, whether it's a community-based service, I think is more difficult in community-based services than if it's an inpatient kind of service. Because if it's an inpatient service, or if it's an outpatient like care practice, for the most part, they don't have to be cared about. They don't really have to get involved in those details. If a person refuses shelter placement upon discharge, most hospitals will just release them out into the street. If a patient is being seen by a primary care practice and the resources are just not good enough, then the patient is just back out in the street. There's not really much you can do. But if you use a housing first model and you have that person stably housed as a part of those services you're providing, then I feel like you really can close that gap. And in most cases, the social workers, peer specialists, community health workers, case managers, nurses, whomever, providers, physicians, whoever wants to engage with that patient at that location, more likely than not will be able to find them. And I've had so many stories. I would spend the whole entire day talking about how successful stably housing, providing stable housing for someone first, has really had an enormous impact in their outcomes, because of the fact that this patient could be found, right? And so you can plan care, you can stabilize that person's situation a little bit more, because you can get things to that individual. So the question here is, why does Mr. Johnson keep landing in the ER? So here's some factors we could think about. No continuity of care. Homeless patients often get Band-Aid fixes. They have no address and no follow-up. We were talking about that. Stigma. ER staff sometimes dismiss him as a non-compliant, drug-seeking, missing the root causes. This is that right there is the one that's the reason why I went on that tangent describing that situation about my aunt, because I feel like although she wasn't drug seeking, once that mental issue comes into play, then you got to deal with the stigma.
Yeah,
the stigma comes right along.
The stigma was there, and they didn't know that she had nieces who were in the medical field.
And it was interesting. They had transferred her to another hospital because, again, always if she's going to get surgery, yes or no, turned into a whole thing when she was transferred. And when she was transferred to this other hospital, one of the nurses, who was, mind you, the whole time she stayed there, she spent most of her hospital stay actually at this other hospital. Hospital that was within the same hospital system, but at their hospital that specifically would help if she was going to move forward with the surgery. That's where the surgery would happen. So she was transferred to another place, another hospital. But this other hospital she was transferred to, of all the nurses that was caring for her, only one was Black. And it was the only nurse that actually explained to me that while my aunt was in the hospital with that respiratory, virus infection, she still cracked her door open. And she said, she said, I just personally have an issue with patients who we have to use wrist restraints also being in a closed door, like in a room with a closed door. Now, of course, as a nurse who does not work in the hospital, but has visited many patients in the hospital, coordinate care with the inpatient team, I have to say I was quite impressed with not only the fact that she explained it to me, but that's where her heart and her mind was at, because I didn't see it that way. I felt like I needed to be there to advocate for her, not in my aunt, and I did need to be there to advocate for her. But that was something that showed me kind of like, wow, at least there's some type of dignity here, because once a person has a virus, you can always justify closing the door. Did you say we're trying to keep that virus contained? But it also closes the door on the other side. So you have this person who was on the other side of the door, who could be feeling very isolated, very confused. She was pretty confused about like, well, what's going on with me? Hospital acquired psychosis is a thing, so some people just being in the hospital. I mean, how many times have you gone on vacation and you come home from vacation and sometimes miss the days? You're like, well, what day is it? Because you're kind of off of your schedule when you're on a vacation and you don't have your work routine, you don't have your dog walk routine, you don't have your coffee routine. So you're off your routine, and then you come back to your life after you left your palm trees in the sun and the sand. You come back to your life and you're like, oh my God, what day of the week is this? Is it Tuesday? Is it Wednesday? And imagine if a person is in a hospital and they have that confusion already, that hospital stay is just adding on to the confusion. And then even worse, if you're isolated with the door closed, then you also don't see any kind of familiar face, or you don't have some type of way of kind of connecting with people. And it was a real concern for me, because I spent my entire day with my aunt when she was going through, this hospital stay. And I can tell you that I didn't see physical therapy until the day she was discharged. And it was just to evaluate her for her discharge. I did not see an aide come in to feed her. There were days that I had to actually do her personal care because there was no one doing it. And I only say that because if I come at 11 a.m., I'm thinking personal care and breakfast should already be served and be completed. And that wasn't the case, right? And so therefore, I just started to make my presence known a little earlier. And again, I've never had an issue where somebody was coming in to provide care that I was doing. So therefore, I kind of look at it from the standpoint of, I know some folks are going to say, especially if they work in the hospital, they're going to say, well, sometimes when the family's there, you just want to give space. That may be true, but I think it's important to let the family know that if, at least acknowledge, hey, if you're in here doing X, Y, and Z, do you mind if we come in at this time and do that? Or, hey, since you're here, would you mind assisting me with this? Or are you guys going to be feeding her? Are you guys going to be doing her personal care? Because at least it lets the family know that this was something that was on your radar and on your schedule. But I'm telling you, that's not what I experienced. And it could actually have a double, kind of a pile on, the confusion, the respiratory infection, and then also the fact that and this is an interesting dynamic. She actually, for an older adult, she doesn't have a lot of medical issues. So she was not the type of patient that you were going in frequently to do like blood sugars with. They knew exactly why she was in the hospital, and she was very stable. And every time they came to do their vitals, she was always looking good, and her vitals were always stable. And I think that also contributed to the issue. So you have the confusion, older adult, not a lot of issues. So you're not coming in that room constantly for blood sugars and things. So it just created the perfect storm for her to be neglected, and then added the NPO status. I think they did that like maybe 1 or 2 days, and then they stopped doing it when they decided they weren't moving forward with the procedure. But even with that had to be something that I had actively got involved in, where I mean, 2 different nurses actually had to reach out to the surgical team and say, hey, what are we doing? And they did it in front of me as I prompted them. Which is another reason why I assumed that they could just be short-staffed, because did I need to come and tell you to ask a surgeon, what are they doing? But there's also another issue: race and age. African Americans face higher heart failure rates, and elderly homeless adults are the fastest growing group. And you add substance use, and it's a perfect storm.
Right.
Yeah.
So what are your suggestions? Like, I gave my suggestions. What do you think would work to help us?
Well, again, I've seen the housing first model work. I've seen that work. I think that if your program, because how should I say this? I mean, if you're providing outpatient care and you're not under a particular program or expectation of, the patient you're serving is one thing. But for the most part, every outpatient, inpatient practice, hospital system, they know the patient population they're serving. I think there needs to be more attention paid to doing something like gaining actionable insights from that data, and then also understanding the financial implications that really come with having ignored some of these issues. Because I think the immediate gratification of having like a short staff unit, or you have a program where you want community-based workers or community-based nurses or social workers or physicians out in the community providing this care in the patient's home or wherever they may be. All of it sounds good, but if you really don't think about the best way to utilize and support those individuals, you may be saving money in one area, but then you're losing tons of dollars in another area, because you have burnout, you have turnover, the issues around burnout. We really seen a lot of conversation around it related to the international crisis, due to the pandemic. And that was one of those times where they could not hide how frontline professionals and essential workers, especially essential healthcare workers, felt about, being burdened with these responsibilities, because everyone already felt that way. People already knew, oh my God, if I had to work out in the community and if I had to be client facing in people's homes and everything, I know I'm probably not going to get enough face masks. I don't even get enough time sometimes to get a lunch break. So if they have to give out buku face masks, they're probably going to tell me, here's your face mask for the week. And this is what a lot of people experience who were direct, frontline workers. They were just given like a wish and a prayer and a face mask for an entire week. And then there started to be a lot of issues around, people not wasting face masks. So there was a thing where there was a practice where face masks were kind of like, like people would use like a paper bag or something to kind of like store their face mask, and they would put it in their lockers or put it in their the staff units, the lounge and whatever, and then they would have to use it again. And I heard this one story, which I thought was the strangest, that they were sharing face masks because of the desperation. Exactly. And is it no surprise that whole entire unit became positive for C-19? No, that's not surprising. But that's the kind of thing that happens when you're trying to save money in one area, but then you wind up spending a lot of money in the next area, because some of these hospitals did not survive that pandemic, and they actually closed because of the fact that they had lost, so much staffing, or had to put off so much of their money making procedures. So it's better to.
How can they share masks, like when the first rule of prevention is discard and destroy?
a better question would be, how could people who are in healthcare, who are putting the face mask on for the sole purpose of, preventing that kind of exposure, put themselves in that situation? How, like, but see, what happened is, when you created a situation where you told people, you know, you're giving them a prayer and a wish and fingers crossed, then people start acting in desperate ways. I mean, I've heard stories of nurses during the pandemic where they would come onto the unit. They would, like, case managers or social workers would come onto the unit, and they would just barely open up the unit door, talk to the nurse from the unit door, and every single thing that needed to be taken care of for that patient, they expected that nurse to do it, because they did not want to come on the unit because of, again, all of the red tape around wasting face masks and reducing exposure. And so, I mean, again, and I think sometimes when I reflect on that time, not that any of those things have necessarily changed, but I always think to myself, and this is probably something I had noticed. I always think to myself, this is probably exactly what I noticed long time ago, 14 years ago, when I became a nurse, way before even the thought of anything like a pandemic was even crossed my mind. I think when I was in nursing school, that was like one of the things that came out was swine flu. I think we all had to get the swine flu vaccine. And so I remember, like, when I say all of us, I'm particularly talking about my classmates when I was in nursing school. And so even with that, I just remember thinking to myself, look, somebody could tell you that you have to have a vaccine. It didn't matter if it made you sick. It didn't matter if if it didn't help you out. You just need to have it if you're going to work in a hospital. And I just remember thinking to myself, I don't think I want to work in a hospital. I just remember just saying to myself, if I'm going to do something in healthcare, it has to be something that's more like social determinants of health, mental health focus. I couldn't see myself just inside the hospital, but I do take my hat off for nurses who work in the hospital. And this conversation is no dig on them, but I think that oftentimes, if we don't really take a look at the data that we have access to, and I do encourage nurses to look at this information as well, we won't be able to pull those actionable insights for us to really make change. Somebody like Mr. Johnson in the city of Philadelphia and some of our major hospital systems, and we have some of the largest hospital systems in the country right here. We have clusters of them here, right in here in Philadelphia. And I just find it's interesting that, people like Mr. Johnson even exist, because so many people in the Philadelphia area are like Mr. Johnson. So it makes you think to yourself, how is it that we could even have an outpatient provider practice profess to be taking care of low income individuals who are not stably housed, and you don't have real resources for them? Your resources is to have the community health workers and the nurses take on the burden of connecting these individuals with resources and ignoring their mental health issues. And the mental health issues, including with that the substance abuse issue, is one of the main reasons why this individual is okay with not being housed.
Right.
So that's another issue too. Having behavioral health and mental health be a cornerstone of your services. The assumption, and that is a big farce, the assumption that someone is not stably housed because they just couldn't find the time to find housing is foolishness. In most cases, individuals are not stably housed because they have some unaddressed mental health issue. So if you don't have mental health and behavioral health, I'm talking specifically about practices that they're serving individuals that they know they're not stably housed, because Mr. Johnson's biggest problem in this situation is not just it's the housing. It is the housing first is his biggest issue right here. But again, it's crazy because as much as his housing is his biggest issue, we know that we can't tackle the housing if we don't tackle the mental health issues first. We have to find out, to answer your question about solving problems with individuals like Mr. Johnson, we have to find out what is contributing to the mental health issue.
Yeah.
Is it
So
is it
it is.
stress? You know, is it that
Is
you
it
need someone to
lack
help
of
you with your
housing? Yeah,
right? Is it right? Because that could be its own cyclical issue there. The lack of housing, the stress of that. You're using drug, you're just using it to numb yourself, and you're just going through a cycle. And no one is saying, you know what? Let's get you to some treatment first, because no one in this, when it gets cold, in this region, the Philadelphia area, it gets really chilly about sometimes late November, mid-December-ish, that area.
right.
That's when it really starts getting cold. When you see an individual, because that is the period of time where usually you have an increase in hospital stays, because a lot of times individuals who are chronically homeless will then try to go into the hospital and get some of those needs met. Maybe some of them become more sick and therefore they want somewhere to be stable, to get some care. And you'll have an increase there. But again, if you see someone who's homeless and they're in and out of the hospital during those months, that should really indicate for you this person is saying that they're going to be out in the snow. It's freezing cold. They're going to be outside in that freezing cold. How could you deal with that person as if the only thing that they have going on with them is the cardiac issue?
Right.
If you don't address the underlying mental health issue, you won't be able to get that major issue, which is housing, together. So the answer to my question is, practices should know the population that they're serving, and they should try to pull inferences, and pull whatever insights they can from the data they have about how to effectively serve these individuals, so that you don't have social workers, case managers, nurses, community health workers, whomever, working with these individuals and expected to make huge impact with individuals who are clearly above what they can do. It's out of what they truly can do because of the lack of resources and support. So that's a high level system issue that has to be addressed. It's not something you can necessarily, just like my aunt situation, I really can't put that on the nurses that there's not someone available to feed my aunt. Right. How could I do that? It's like they don't come with the staffing.
Right.
So you have a bigger issue that you have to address from a leadership standpoint of how do we now make sure that we are properly staffed, we have the proper resources so that people aren't burned out. And in the case of the pandemic, people aren't sharing masks.
Crazy, right?
Yep, it is.
Yeah, it's just very, very strange how everything is. It's just, I think also with me, I always look at things as preventable. And all of this is prevention, because if you make sure that someone has housing and adequate housing, then like you're cutting off a lot of his problems. And this is what would happen in Mr. Johnson's case. But I think the medical field is no longer interested in prevention, and rather it's interested in how much money can we get from each individual. And it's sad, but it is what it is, right? So that's my thought.
Well, I want to say thank you for taking the time to meet with me. It's always a pleasure to speak with you. We know that cases like Mr. Johnson, they're not unique. It is a wake-up call. It's a call to action for all healthcare professionals. Healthcare isn't just pills and procedures. Right. It's about dignity, right? It's about housing. It's about compassion. If you want to be a part of change, then every single day you have to fight and advocate for changes on the front line and also to happen on that higher level. Okay, right. So being comfortable talking to management and leadership. This may actually require that you yourself, make the effort to continue on with your education, and so that you can be one of those decision makers. So again, we want to hear from you. Schedule a free consultation
or send us an email at advancednurses@acd4n.com or visit our websites www.advancednurses.info or www.acd4n.com.